So today we are going to discuss about an important topic in head and neck, which is parotid gland, which often comes as long as a question in the university papers. So the parotid gland is the largest of the three pairs of salivary glands, the other two being the submandibular and the sublingual glands. This is composed entirely of serous alveoli, and it is lobulated, yellowish brown in color, and weighs about 25 grams. The location of the parotid gland is that it lies in the pyramidal fossa, posterior to the ramus of the mandible, called the retromandibular fossa or the parotid bed. So the boundaries of the parotid bed are as follows. Anteriorly, it is bounded by the posterior border of the ramus of the mandible, as we can see here. Then posteriorly by the mastoid process. Superiorly we have the external acoustic meatus, and medially we have the styloid process. We can see the styloid process here. So anteriorly by the posterior border ramus of mandible, posteriorly by the mastoid process, then superiorly by the external acoustic meatus, and medially by the styloid process. Now this parotid bed is lined with several muscles to make it soft. For example, the ramus of the mandible is covered by two muscles. We have the masseter laterally and the medial pterygoid, which is located medially. The mastoid process, as you can see here, is again covered by two muscles, the sternocleidomastoid laterally and the posterior belly of digastric, which is located medially. The styloid process over here is enveloped by three slender muscles called the styloglossus, stylopharyngeus and the stylohyoid. Now the parotid gland is very soft and it is not easily palpable, but the parotid bed can be identified by the bony boundaries. The extent of the parotid gland is as follows. It extends from the external acoustic matter superiorly to the upper part of the carotid triangle below. Then medially it extends to the styloid process and it wraps around the neck of the mandible, and anteriorly it extends over the masseter for quite some distance. Posteriorly it wraps or it overlaps the sternocleidomastoid. As you can see the sternocleidomastoid here. A part of the parotid gland, it extends forwards and is often detached from the main gland, and this is known as the accessory parotid gland. Several ducts from this accessory gland opens into the main parotid duct. The next important topic is the parotid capsule. So the parotid gland is enclosed by the fibrous capsule, which is known as the parotid capsule. This is formed by the tough investing layer of deep cervical fascia. This fascia splits in the region between the angle of the mandible and the mastoid process to enclose the gland. So this it is split into two parts, the superficial lamina and the deep lamina. The superficial lamina, as we can see here, is very thick and it is unyielding, strong and adherent to the gland, while the deep lamina is thin. The superficial lamina, it blends with the epimysium of the masseter muscle to form the thick paretidomasseteric fascia, which is attached about to the zygomatic arch. The thin deep lamina is attached to the tympanic plate and the styloid process of the temporal bone. It thickens to form the stylomandibular ligament, which separates the parotid and the submandibular glands. While talking about the parotid capsule, we have to talk about a clinical correlation, which is mumps. Mumps is a virus-caused infection which causes the inflammation and the swelling of the glands. So the parotid swellings are very painful, mainly due to the unyielding nature of the capsule. So any inflammation or tenderness will cause severe pain. This is due to two main reasons. The first one is stretching of the capsule, and the second reason is the stimulation of the great auricular nerve. So this pain is usually increased at meal time due to the increased secretions in the parotid gland, which further increases the turgor within the capsule. But after the meal, this pain recedes. The parotid gland resembles a three-sided pyramid which has an apex which faces downwards. It has four surfaces: the base or the superior surface, the superficial or the lateral surface, the anteromedial surface and the posteromedial surface. It has three borders: the anterior border, the posterior border and the medial border. Talking about each feature, the apex, it projects downwards, overlapping the posterior belly of the digastric muscle and the adjoining part, the upper part of the carotid triangle. The two structures which emerges from the apex, this is the apex, we have the anterior and the posterior division of the retromandibular vein and the cervical branch of the facial nerve. The two structures. Then the base or the superior surface, it is related to the external acoustic meatus and the posterior aspect of the temporomandibular joint or TMJ. The following structures emerge from this, which are the superficial temporal vessels, the superficial temporal artery and the superficial temporal vein, and the auriculotemporal nerve. The anterior border separates the lateral surface or the superficial surface from the anteromedial surface, and from here we have the following structures emerging in the radiating fashion, which are the four branches of the facial nerve, which is the temporal branch, the zygomatic branch, the upper and the lower buccal branches, marginal mandibular branch. Only the cervical branch emerges from the apex, rest all the four branches emerge from the anterior border. Along with that, we have the transverse facial artery and the parotid duct. So remember, the parotid duct emerges from the anterior border of the parotid gland. From the posterior border, we have the posterior auricular nerve and the vessels. The posterior border separates the lateral surface from the posteromedial surface. Then the medial border, which separates the anteromedial and the posteromedial surfaces, is related to the lateral wall of the pharynx. As we can see here, the medial border is related to the pharyngeal wall. Now talking about each of the surfaces. First, let's talk about the superficial surface. It's the largest of the four surfaces and it is covered from superficial to deep by the skin. Then we have the superficial fascia. Then we have the deep fascia, and along with that we have the deep parotid lymph nodes. Skin, superficial fascia, then we have the deep fascia and the deep parotid lymph nodes. Then the anteromedial surface, it is deeply grooved by the posterior border of the ramus of the mandible, as we can see here, and it is related to the masseter, the ramus of the mandible, the medial pterygoid, and also the lateral aspect of the temporomandibular joint. Then the posteromedial surface, it is mounted onto the mastoid process and the styloid process and the associated muscles. So the mastoid process is related to the sternocleidomastoid and the posterior belly of the digastric, where the styloid process is related to the styloid group of muscles, the stylopharyngeus, styloclossus and the stylohyoid. The styloid process and its muscles separates the parotid gland from the internal jugular vein, the internal carotid artery and the last four cranial nerves. Two structures which enter the gland through this surface, the facial nerve trunk as well as the external carotid artery. The two structures are the external carotid artery and the facial nerve. Writing an answer about the parotid gland, it would be incomplete if we do not mention about the structures which are present within the gland. The three important structures from the superficial to the deeper aspect of the facial nerve, the retromandibular vein and the external carotid artery. First, let's talk about the facial nerve, which is the most superficial structure. So, as we saw in the previous topics, the facial nerve enters the gland from the upper part of the posteromedial surface and it divides into the terminal branches within the gland. Now, these branches, they run horizontally and after some distance, they leave the gland through the anteromedial surface and appear by passing underneath its anterior border. So these five terminal branches, that is temporal, zygomatic, buccal branches, the upper buccal, lower buccal, marginal mandibular and the cervical branch, all the five together have a goose foot like appearance. So this is why it is known as a pes anserinus. So if pes anserinus is given somewhere, do realize that it is related to the facial nerve. The next, talking about the retromandibular vein. The retromandibular vein occupies the intermediate zone, that is between the facial nerve and the external carotid artery. This is formed by the maxillary vein as well as the superficial temporal vein, which joins from the retromandibular vein. Then it divides to form the anterior and posterior division, which leaves the gland through the apex. The anterior division, it joins the facial vein to form the common facial vein, whereas the posterior division joins the posterior auricular vein to form the external jugular vein. Last, we have the external carotid artery, which occupies the deepest zone of the gland, and it pierces the lower part of the posteromedial surface to enter the gland. Within the gland, it divides into two branches, that is the superficial temporal and the maxillary arteries. The transverse facial artery, which is a branch of the superficial temporal artery, also emerges from the anterior border along with the branches of the facial nerve, as we saw in the lesions. Next, we have the Patey's facio-venous fling. So the parotid gland, as we can see here, is divided into a large superficial lobe and a deep lobe. So large superficial and a small deep lobe, and these two lobes, as we can see, is connected by an isthmus, and it is through this edge-shaped isthmus that the branches of the facial nerve passes. So the plane between the superficial and the deep lobe through which the branch of the facial nerve as well as the retromandibular vein lie is known as the Patey's facio-venous fling. So why is this plane important? This is important because it helps the surgeons to remove the parotid tumor, making sure that the nerve, that is the facial nerve, is not damaged. Then a clinical correlation here would be the mixed parotid tumor. So mixed parotid tumor is a slow growing, painless tumor of the large superficial part of the parotid gland. It is so called because of its mixed histological appearance, and now it's called the pleomorphic adenoma. After many years of benign growth, it can undergo a malignant transformation. The duct is also known as a Stenson's duct, and it measures about 5 cm long, which emerges from the middle of the anterior border of the gland, which we have already seen, and this opens into the vestibule of the mouth opposite the upper second molar tooth. It's very important to know the location of the parotid duct. Talking about the course of the parotid duct, the course is as follows. After it emerges from the gland, it runs forwards over the masseter. We can see the masseter here. It runs over the masseter between the upper and the lower buccal branches of the facial nerve, and at the anterior end of the masseter, it takes a 90-degree bend. This is the first bend we can see here, 90-degree first bend, and it pierces the buccal pad of fat. Okay, then it pierces the buccopharyngeal fascia and then the buccinator muscle. The structures pierced are the buccal pad of fat, buccopharyngeal fascia, the buccinator muscles, and then after piercing the buccinator muscle, the parotid duct again runs forward by taking the second bend. We can see the second bend, 90-degree bend here, for about 1 cm between it and the buccal mucosa. Then again it turns medially with the third bend and opens into the vestibule of the mouth, opposite the second molar tooth. So this tortuous course of this duct, it acts like a mechanism to prevent the inflation of the duct system during the excessive blowing of mouth, like as we can see in case of trumpet blowing. The surface anatomy of the parotid duct is also important. On the face, the duct is represented by the middle third of a line extending from lower border of the tragus to the midpoint of ala of nose and the red margin of the upper lip. Talking about the clinical correlation over here, the probing of the parotid duct is difficult. Why is it difficult? Because of the tortuous course. As we can see, there's lot of bends, the first bend, the second bend, the third bend happening. So because of this very tortuous course, the probe is held at sharp bends of the duct, so it is very difficult to probe the parotid duct. The parotid duct lies 1 finger breadth below the zygomatic arch. So when the teeth is clenched, it may be rolled up and down against the masseter muscle. Also, because the parotid duct is a superficial structure on the face, it can be injured during the any injuries to the face, or it may be cut during surgical procedures that occurs on the face. Also, there can be small stones or calculi that may be formed in the parotid gland and the duct, and this calculi can lodge in the distal portion of the gland and it can be removed by splitting up the duct from its opening in the mouth. Also, we have the parotid cyelogram, in which we inject a radiopaque dye through a fine needle or cannula inserted into the mouth of the duct in the vestibule of the oral cavity, which can be used to demonstrate radiologically the ramifications of the parotid duct. Talking about any gland, we have to talk about its nerve supply. So the parotid gland has three type of nerve supply. It has the parasympathetic supply, the sympathetic supply, and the sensory supply. First, let's talk about the most important, or the secretomotor, or the parasympathetic supply of the parotid gland. So this is provided through the auriculotemporal nerve, which relays in the aortic ganglion. So the preganglionic fibers, it arises from the inferior salivatory nucleus in the medulla, and it passes to the glossopharyngeal nerve, which is the 9th cranial nerve. Then the tympanic branch of the glossopharyngeal nerve, also known as Jacobson's nerve, the tympanic plexus, and then the lesser petrosal nerve. Then it relays in the aortic ganglion, from where the postganglionic fibers are passed through the auriculotemporal nerve to supply the gland. So this much, the initial part is the preganglionic fibers, whereas this is the postganglionic fibers. Next, we have the sympathetic supply, which is derived from the sympathetic plexus around the external carotid artery, formed by the postganglionic fibers, which are derived from the superior cervical sympathetic ganglion. So preganglionic sympathetic fibers arise from the lateral horn of the T1 spinal segment. And the sensory supply is derived from the auriculotemporal nerve as well as the great auricular nerve. The clinical correlation to remember here is a Frey syndrome, also known as the auriculotemporal nerve syndrome. So sometimes some wounds of the gland may damage the auriculotemporal nerve as well as the great auricular nerve. So the auriculotemporal nerve, we know it contains the parasympathetic, sensory, and the sympathetic fibers. The great auricular nerve contains the sensory and the pseudomotor fibers. So when these nerves are cut during the regeneration, the fibers, they grow into endoneural sheets of fibers, supplying the cutaneous receptors for pain, touch, temperature, etc. So when a stimuli intended for salivation is evoked, what happens is that there also occurs sweating, flushing, etc. So Frey syndrome is characterized by when a person eats, the ipsilateral cheek, it becomes hot, red and painful, and also there will be excessive sweating, also known as gustatory sweating. That is, along with salivation, there will be sweating also. Also, when a person shaves, there is cutaneous hyperesthesia in front of the ear. This is due to damage of the auriculotemporal nerve and the great auricular nerve. Next, we have the vascular supply and the lymphatic drainage. The arterial supply is by the external carotid artery and the superficial temporal arteries, whereas the veins that drain is by the retromandibular vein as well as the external jugular vein. The lymphatic drainage, it drains the superficial and deep parotid lymph nodes, which further drains to the deep cervical lymph nodes. Talking about the development, the parotid gland is of ectodermal in origin. It develops during the 6th week of the intrauterine life. When does it develop? The 6th week of the intrauterine life, as part of cells with the proliferation of the ectodermal lining of the vestibule of mouth near the angle of the primitive oral fissure. Then it grows backwards towards the ear, branches repeatedly, and further forms a parotid gland. The parotid bud and the branches, they canalize to form the duct system and the ascent. So this is all about the parotid gland and the parotid duct, and also the nerve supply, vascular supply, the relations, etc. To make sure that you learn the relations of the parotid gland very well, because it often comes very frequently in the university papers.